Good morning, Dr. Rapulu and Dr. Reddy. Are you on? Oh, good. We see both
Good
of
morning,
them.
sir.
Good
Good morning,
morning.
sir. Good morning.
Yes, good morning here, myself, Dr. Keeney and Mount Sinai Cath Lab for this our educational live series, episode 22. And we're thankful to both of you to be there. And we have a very beautiful case with multiple disease vessels which need to be taken care. And if that's okay, as planned, we want to just start our presentation. You can hear us well and see us well, but we can see both of you very well.
Yes, sir.
Okay, beautiful. So this is our complex coronary live case series from Mount Sinai Heart in collaboration with CCC Live, which actually has been a great success with India being second with about 17% of our patients, which are about, 17% of the total viewers, which is about 18,000 per month. America is number one with 25%. So, and this is now in association with the CME Mediquest. So this we need to understand that whether CME credits will be given or these live series that we need to just contact our local administrators. So here, myself and Dr. Keeney, no change. And then of course, both of you as a guest faculty and moderator with Dr. Rapalu and Reddy. Both I just want to say a few words about. One, our young, I would say budding cardiologist, interventionalist, Dr. Karunakar Rapalu. He's a consultant cardiologist at Apollo Hyderabad and he completed graduation from DM and DM from Osmania Medical College and has been very active in various societies and great in complex interventions and peripheral interventions. So we're happy to have you with us. Then Dr. Reddy, our senior, very renowned cardiologist and professor at head of department of Osmania Medical College and senior consultant at Apollo Hospitals, Hyderabad, has been a pioneer in various teaching and of course educating many fellow cardiologist and has a great reputation and over 50 publications and also at present going on with the global clinical trials of the SELECT and ZEUS and many other trials. So clearly happy to have both of you for this interesting case. And after the case presentation, once we do this case for about an hour, then we have 30 minutes discussion on a protected PCI for chip case. Which you'll be presenting, and then we have interactive panel discussion. So with that note, we come to our live case number 22. This patient actually is not much in terms of medical history before. 79-year-old, few months ago presented with non-STEMI. And then still didn't want to get anything done. They did a stress test, which was markedly positive and was in heart failure. Basically with a reduced ejection fraction, because EF was about 28 to 30%. A patient have a CVA but no residual, used to be uncontrolled factors, but since hospital admission has been very controlled in terms of diabetes, hyperlipidemia and hypertension. So then the EF consistently has been around 30%, but we started on good medical therapy and had a cath done. Patient was transferred to us for management with a severe three-vessel disease with both calcific bifurcation RCA, PDA and AV continuation, LED diagonal, and thrombotic circ OM. And likely that was the cause of the non-STEMI. High syntax score. So at that time, since patient was still in heart failure, we started guideline-directed medical optimization, and then patient was referred for CABG because of high syntax score and LV dysfunction. And the patient did have discussion, but then declined, and today is for PCI of the circumflex and rotational atherectomy of the LED diagonal. So Anu has done the baseline picture. In this particular case, Anu, share us now.
They can show the angiogram.
Yep.
So EDP was about 12. So echocardiogram, I know here EF looks about 35-40. We got an echo with the EF of 30 with no valvular issues. And this is where we are with his right coronary artery, non-obstructive with the sense proximate distal heavy calcium, but diffusely diseased PDA,
Yep.
and subsequently even the RPL. all distal disease. And here we have the circumflex. In the left vein is non-obstructive, totally occluded circumflex, which is a branching vessel that you can see.
That's the calcium
And,
of the LED on the
yeah,
top.
and calcium of the LED before we inject. Tram track calcium, which is heavy calcium, which you see here again. And disease in the mid LED, which is bifurcation, about moderate size, diffusely diseased diag. And distal LED, again, heavy calcium disease all the way up to the apex. That's where we are with him. So,
And actually, that was the region surgeon said that we are very diffusely diseased. So it's not a great case because all vessels are calcified. Because severe calcium is bad for interventionalists. Actually, it's bad for surgeons also in terms of the grafting. And secondly, is also basically early graft occlusion. So both those factors comes into play with this patient decline. So patient, this was done in June, and now patient came for this intervention. So we come back to quickly, let me complete my presentation, and we'll go back here. Slides, please. So this is our plan today, and we use Impella, and I'll come back to reason why we use Impella in this particular case. As you know, the latest, our guidelines, you need to present all these cases. Additional aspect besides what we are doing, heart team discussion, STS risk calculation, as well as syntax score calculation. Actually, the latest data, they have given less importance to syntax. They usually just talk about complexity, but syntax, see that is 2B. The STS and heart team is level 1, class 1. So syntax, they really downgraded. So, and more important, they're given to the frailty. Based on the various factors, there's from 1 to 9, this patient comes out to be frailty about 4 in terms of how they can walk and take care of their patient, take care. So this patient, syntax score is 33 and STS is 3.1. So anything more than 4 is bad, but it's a little lower. So this is basically using the physiology in case you need it. And this particular patient is because of the multivessel disease is appropriate for intervention. And the question then comes down to that because of LV dysfunction, which is on the right side, multivessel CAD and LV dysfunction, first treatment, class 1. What remain only class 1 now is 3 vessel and LV dysfunction. So remember, there were a lot of, we have pushback from the surgeons that 3 vessel disease of the diabetics and all that have been taken out. Only one class 1 remain now is the ejection fraction is low. It's a class 1, otherwise they become class 2 or 2B. Very important difference. And second is the patients who are not suitable candidate for CABG, they're okay to go to PCI after heart team discussion. So that's the important addition which we have. Now, of the assist device, why would you need it? Because of severe LV dysfunction. There's no other option here. Surgeons already have declined the case. So you need to be fully prepared with a balloon pump. PTVA tandem heart do rarely, particularly if there is LV thrombus. Otherwise, Impella is the way to go nowadays. Even in India, rare cases are done, small numbers, but still using Impella in these cases with the severe LV dysfunction, with the whether you use 2P, 2.5 or CP, which gives you about 4 liters. So this is our common graph that you combine both lesion morphology or complexity along with the ejection fraction. As you know, at present, the trial is ongoing with the EF less than 40% and complex CAD, randomizing them to standard of care, many of them getting a balloon pump, versus CP Impella assisted PCI. So this is the Protect 4 trial. We actually are the leader at present. We have done about 33 plus cases of the 190 which have been done. So this case will be appropriate even outside the trial. Now, why we could not randomize this patient in the trial? Because we are issue about the patient's overall social conditions and follow-up. So this patient was not randomized. Otherwise, it would have been a good case for randomization in this trial. But key is that patient with a complex CAD is appropriate to go use Impella, and this is what we did in this patient, little high EDP and severe 3 vessel. EF although looks a little better now, but we have a echo as of yesterday, EF of 30%, which is only minimal MR. Yeah. So do you agree with that Impella's choice in this particular case, or we have some discussion further on?
I think it is quite good morning, Dr. Samin Sharma and Dr. Annapurna and other team members. I think myself, Dr. K.M. Reddy and Dr. Karunakar as our guest faculty is there. probably we're going to see the things. It's a good choice, and probably it needs definitely a mechanical support in the form of Impella. I think it's a good choice. There is no doubt about that. Please go ahead.
Okay.
Okay.
Anu, tell
So
us.
this is the groin picture where you can see, big, large femoral vessels. We do see some calcium and tortuosity, but this is acceptable to do the Impella. We did 2 pre-close, and we have the Impella with the single access. We already showed this picture now. There's the Impella there. So now,
It's a single access.
yeah.
So one puncture, and you can put up to 7 French sheath through the same catheter. So
Yeah.
they can show with the ceiling, show the hemodynamics on one side. Please always show the hemodynamics. Okay, keep going. The camera.
So this is where the circumflex, if you see here, LED I showed you. So the circumflex long left main. So when you have long left main, usually, wiring the circumflex could be a little challenging. We just use a fielder wire. You can see that?
Single access, yeah.
Single access.
Yeah.
And that I would say the CP, although is more expensive, but single access has really reduced our vascular complications. Yeah.
So the fluorosave, you can see it there. We
Yep.
use a fielder wire to get into it. Let me just show you where the circumflex. Now his creatinine is 1.4. Elderly patient, so we don't want to get too many pictures. I showed it already. Left main, which is non-obstructive, but look at how the circumflex takeoff is. So went with a fielder wire. With a fine cross. So we like to use fine cross, but you could use a Corsair, Turnpike, whatever your choice is of the over the wire catheter that could be used. So now once I reach there, you see that with the fielder wire, we are trying to navigate always when you have a CTO, you try with the soft polymer jacketed wire, whether it is fielder, whisper, you want to use pilot, you want to use fielder XT, any of this wire of choice you could use there. And once we know we're not able to go any further, now you go with the wire with the higher tip load, which could be used for drilling. So again, you could go to Gaia series or a Miracle. I like Miracle because you are able to make a better curve. We use a Miracle and we were able to cross with the Miracle. So the 2 branches, we went to the upper branch, then we change into the run through, long run through, pre-dilated, put a stent, and this is where we are. You have a nice branching circumflex. Now,
Beautiful.
really if you wanted to go aggressive, we could go back to the lower branch, open that, but we left it like this for him.
Good.
So now we are for the LED. I'm going to go back so we can have a plan for the LED. This is where we are with the LED. This definitely we will need a rotational atherectomy. The question is,
Direct wire.
there are no fielder fine cross, multiple lesions. What all are we going to tackle?
Yeah.
I
So
would
yeah.
not do bifurcation with this.
Yeah. So question comes is, so there is a disease at the diagonal, and of course further down. Ostial maybe not that bad, but it's there. And then of course the real disease in the LAD is after the diagonal and of course further down. So a lot of disease downstream. I think we can leave that alone. We should concentrate on the mid LAD and the diagonal, whether you come out with the 2 stent, one with the crush technique, because basically issue in this patient is the reliability,
I
the
would
follow-up.
leave the diagonal alone because the diagonal has a lot of calcium. Okay, it's not going to respond either to your PTCA alone or cutting balloon and long disease. So just focus
1.75
on
bar.
the LED. Yeah.
1.75 bar.
175 bar. The only question is that since there is diffuse disease distally, would we cause slow flow when we are doing the prox LED rota?
Right. So this is a little unusual situation that you have a disease of the calcium.
Do distal
Huh?
all the way down, leave it, right?
If we want to go to LV, then we need a smaller bar, 1.25. Get a 1.2.
What I
Yeah.
want to do is do rotational atherectomy 125 all the way to the mid to distal LED.
Yeah.
And proximal with a different bar, but leave the
Go.
diagonal alone.
Okay.
Let's
Okay.
see what
Fine.
they feel.
Fine. Okay. What's your opinion now? Bring the hemodynamics on the left side, please, so that we can keep seeing the LED all the way down. Yeah. Yeah, so tell us what is the strategy. So this is a complex case. I think any choice you want to do, all are correct, maybe different. So what Dr. Keeney suggested, that let's just concentrate where the money is, and that is the LAD, diffuse disease, and we just concentrate on the LAD up to the apex 1.25 bar, and versus take the LAD diagonal. So diagonal actually will require rota. Look at the
Yes, that's
calcific
what
LAD.
will require,
Yeah.
it's not going to respond to just balloon.
Balloon only, yes.
And still we may have under expansion. So let's just focus on the LAD.
Okay, are we okay with that?
Yeah. I think I strongly believe the same strategy. I think tackling probably or going aggressively in diagonal may have some issues.
And highest perforation, as we know, highest perforation occurs in the diagonal.
Yes.
Yeah.
Yes.
Traditionally, I mean the LED system, but the highest are in the diagonal. So we are actually assigned a task to one of our interventional fellow. We have 8 fellows, and of course 1 or 2 always come from abroad. And so task is to look into the aspect of perforation. One, of course, that whether based on the calcification. So we have actually seen the more perforation with the calcification, while did not use the rotablation. So clearly the wire of the rota has to come out, and then you clean and make a loop, kind of jalebi.
Okay. Yeah.
Yeah, so very important. So we have 1.25 bar ready, and that's what we are going to do. It's a Rota Pro. Huh?
Want to go higher view?
No, this
So
is
we
good.
can see.
Yeah, this is good.
Okay.
Yeah. So 1.25, so you can go all the way down. Now, the question is that by having the Impella, will it decrease the slow flow in the vessel? There was a paper a few years ago, not from the Protect trial, but others, showing that Impella did not decrease the incidence of slow flow during rotational atherectomy. But I think part of that has been is we actually didn't observe that also, but it is just basically is the type of cases we use, and so it's not a randomized, but if you take the data, but I would say that Impella actually did not increase much slow flow. It itself is a positive sign, because the cases when we use Impella, like this particular case with a low ejection fraction, long lesion, severely calcified. Those are the 3 main substrate for a slow flow and no flow. So therefore, I know originally from the Protect 2 trial, there was some negative data about the atherectomy, rotational atherectomy causing more non-QMI and so, but it was all because of the lesion subset which were being done. And they found a difference even in the balloon pump versus Impella group, that Impella patients were more complex, more multiple bursts were used, and so forth. So with that note, we have 1.25 bar ready. As you can see, the wire is out, our advanced knob is there, and we are ready to check the speed. And this is a new console, and that's available also now in India, the Rota Pro. Although the issue has been with the cost and so, the classical, the Rota will go away soon.
Can we make the hemodynamics as a small window?
Yeah, good. We are checking the speed.
Yeah.
Good. No, but purpose-wise, we are going to the apex. So I'm saying maybe
you can move
in the middle. Put this in the middle.
Move it to the left. Yeah, good.
Yeah, good. That's good. Yeah, 30. 2.5, 30. So we going with the push and pull. Yeah, the push and pull. You can see here, the patients get very agitated when they stay longer. But these are the complex cases. Yeah, keep going. Yeah. Still, there is no monorail. What they're working on is not on the monorail, but putting the diamond chips on the proximal end. Right now, it's on the distal end, not at the tail end. So that's the work being done, but not to make it monorail yet. So now we have brought this rota bar.
Just going to 2-3 steps. So we remove all the tension, backward, forward of the knob, the Teflon sheath and the bar. Then here, Y connector, I'm going to just release it and move the bar backward, forward. That's done. So that's the bar and the wire. And the last one will be on the dyna. Yeah.
No movement. Yeah. Good.
I want to pull this back. Pulling the wire back a little bit.
Yeah. Yeah. So try wire in the main vessel. So we go to the proximal segment, they still do some work, but key will be the distal.
Nothing there, right? Okay.
Yeah.
Okay,
Good.
so what we'll do Dyna and then move it with the Dynaglide. So here we are going to do brake release. Here
Yep.
there's a brake you
Yep.
release so that the wire is not stuck, and then I will advance.
Just leave it there. Go with
good,
the
good.
enough room.
Okay,
Yeah,
good.
good. Same thing. You re-platform.
So slow packing motion, backward, forward. Don't come back too much. Like we mentioned, there is no diamond chip in the back. So majority of the atherectomy happens when you're moving forward.
And anytime the wire comes back, you can break, release, and advance the wire. At 1.75 bar to attach. Need to go a little more. Yep. Good. Cine. Yeah. Good. Good. So once it is done, it should do a multiple cine runs.
Good.
Yeah, mean polishing basically. There is a system about single man bringing a single person. We have to put the your clip in that notch with a permanent brake release, and but otherwise once comes out, take the clip out, close the flush, and in this particular case we will upgrade the burr, or the question comes that do you want to use a IVL. So that is the two choices. In the past, of course, before 1 year ago, we didn't have much choices. So now we have the choice that we can go with IVL versus the second bar. Beautiful. Good. So I think we can use 1.75 bar. Tell me, what would you use in your practice, IVL or I know in the past we always use, even now, some cases, we still go with the additional rota bar. Overall, the step bar approach in our lab, we do about 60 rota per month. And the step bar approach occurs in about 8 to 10% of cases. Used to. Now step bar becomes only 2 or 3% because of the IVL. So these cases now we combine with the IVL. So it's basically a little science behind. The notch goes into the notch, and then you put the cover on top. So very important. Once cover is there, you try to separate. Do not means that you have taken, you have advanced and connected correctly, and then of course you're ready to re-platform. So any questions so far? And our participants, if they ask some questions in the
Chat
box, we can answer that. But otherwise, Karunakar and or Dr. Reddy, any other questions from your side? So far, hemodynamically patient tolerating well. And you can see here that with the burr going further down, we are done. The 1.75 will just concentrate on that mid segment only.
Okay.
At the level of the diet.
Yeah. So now question was, could you have gone with the 2.0? I think it's a short segment. Usually our teaching have been, we always have written that do not jump burr more than 0.5. So yes, in this particular case, I think 2.0 could have been, we could have gone with a 2.0 also. But that's a second decision making, yes.
Any burr size at the atherectomy, I think is the plaque modification is the basic science rather than the widening the lumen.
That's it. Yep. Okay, we are checking the speed again. Good. So you know that the Rota Pro comes set at 150, 155 thousand RPM. So you don't have to move it. You want to increase it, then you change. But that is how I set up the device by the company. So that is how it comes.
Okay.
So less fluctuation. That's another advantage of the Rota Pro is compared to a lot of fluctuation used to happen. Now very little happen in terms of drop and fluctuations and so. Oh, wire. No, there is a loop. Loop. Yeah. So what happened is there is a loop in the now.
Pull the wire back.
So yeah, we are going to. So what you do is there are various technique which we said to slowly pull the wire. Still.
Yeah. There.
Yeah. You have to keep it there. Yeah. Good. Yeah. See.
Good.
Yeah. Now it's good. So key is that you have your guide slightly disengage from the. Good. Yep. Very good. So now once you come, you still have to do the same thing again.
Again,
Three
the
steps.
Knob, Y connector, and just a gentle tap on the
Good. Let's
dyno.
start. Yeah.
Okay, so we're going to start burring.
Sorry. 1 second. Good.
Okay, good.
Yeah, he's pressing it there. Yeah. Okay.
There is one question come up. Why you have started with 1.25? Why not with 1.5?
The first one. Yeah, just because we wanted to go very distal.
Okay.
That's I think based on that.
Careful. We
Yeah, I know.
dissect it.
I
Don't
know.
touch it. Don't
Yeah.
touch it.
You just keep it there. Yeah. Yeah.
Get
Pull
the
back a
run
little
through
bit.
ready.
I'm sorry, what? 1 second.
No, get the run through ready.
Yeah, no, we have ready. So what we need to go speed to about 150. So question was 1.25 because we wanted to go all the way to the apex. He said, just show it and then we'll show it. Yeah. Yeah, we can remove everything.
Yeah.
Yeah, good. Cine.
The wire is completely
Yeah, we can take it out. Yeah,
and
yeah,
I'm
we
just
take it
going
out.
to
Yeah.
remove it. Yeah.
Yeah.
Get the
So
run.
just to say that reason was that we wanted to go all the way to the apex and see that 1.25 probably would have been a little too aggressive. So
1.5.
1.2, yeah, I'm saying 1.25 is appropriate and 1.5 would have been a little more aggressive because our plan was to go all the way that calcific in the distal LAD, apical LAD kind of. Yeah, the run through and yeah, let's take a picture now. Good. Okay.
So what we did normally is something that, remember the wire, you need to have a good wire purchase. The way we did it, the wire came back. Ideally it's not a good situation, but now you cannot advance the wire in the diffusely diseased distal LAD. We could dissect it, but then we left the wire there and we did rota almost close to that black portion of the wire. That is an absolute no-no for anybody that's doing otherwise. For us, since we have, experience in doing it, it is acceptable, but you cannot be doing rotational atherectomy with a wire like this close to the black portion.
Yeah. So clearly because that's a spring coil and the burr can unwind it. So clearly that you don't want to do a rota in that area. But key is in this particular case, you have enough room. And that room is good that we allowed us to do a rotational atherectomy. And now we are ready. We'll go all the way to the apex again. This is a run-through wire. Although you can see the wire is preferentially going into the diagonal. Probably is the speaking that crying that please take care of me also. But we'll see. Good. That's fine. Want to see it? Yeah, that's okay. That's all disease vessel. Yeah.
I know.
Yeah. Good.
I want to go to RAO.
Okay. RAO
No,
means
here,
RAO caudal?
this way. So we are apex something.
RAO
so you
caudal,
can
okay.
see the
Yeah.
how distally we need to see in the apex. Take a picture here.
Okay. You want to give nitro?
Yeah, give some nitro.
Yeah, 1 second. Wait.
apex.
Yeah.
We give
So-
some nitro vasodilation. We take a good picture that will give us
Good.
an idea
Yep.
what's the length of the stent and how distally we need to go.
Good. Go. We have to go up to the mustache. Just
No,
before that.
no,
Yeah.
You see that branch?
Yeah. Maybe just up to that
Above
branch.
No, about that.
Yeah. So we can start with a 2.5 or 2.25.
Yeah,
38.
I think 2.5 may be okay.
Yeah, 2.5. So here, many times we decide our stent size that there may be a surgical option in the future for restenosis. There is no surgical option for this case. So I think we have to get a good angiographic result, 2.5, 38, and then 3.038. Yeah. So this is a Zion's,
Why 3.038?
approximately.
No, we don't need 38.
Okay.
23 maybe.
Yeah, we'll see.
You want the whole thing?
Yeah.
No. You're
Okay.
stenting across the dag?
Yep. Yes.
You want to stent
Good.
across the dag?
Okay. Okay. We're going up now. This is the 2.530 balloon and going 10 atmosphere. See that 1.25 bar. As you mentioned that what we are not removing any plaque, we are just modifying it. And modify basically cut in the crack in the calcium.
Down.
Yeah, you want to go a little distal? You want to, in the end, do the IVUS? What do you want to do in the IVUS? I think you should get ready with the IVUS in the end
We
to
don't
show.
have IVUS, no.
Huh? Which, in the imaging, you want to show the imaging in the end?
I don't know.
Yeah,
Okay.
good. Okay, pull back a little bit. Yeah. This, good. Okay, we're ready with the 2.538 stent. Good.
Okay.
12. So it's still low pressure. We are not going much higher because it's a diffusely diseased vessel. Those are the vessel, as I said, has a high chance of perforation. Good.
Okay.
Any questions from our? So I think one question about the burr size we have answered.
Yeah.
So any other? Yeah.
There is a question, actually, it is already answered question. That is the reason why I'm not putting why an Impella was chosen here. I think you already told this, the indication to put the Impella in this scenario.
So I think that one of the reason is, I would say that as an interventionalist in this day and age, the society, the patient, the family, the community expect us that patient has to come out alive. So I tell everybody that no need to cut corners. Be ready in these cases because you may require multiple points. That telling the family may need a rota, may need IVL, and so on and so forth. And of course, using a balloon pump or Impella because of that LV dysfunction. Because these are the patients can just start going downhill very quickly.
Back, huh?
Yeah.
We're not putting two stents
Good.
here, right?
Okay. Good. Rest of them, I'm going up here. Going up.
Okay, good.
Yeah. So this is a 2.5, 38 at 14 atmosphere.
Okay.
Down. Go up again. You know this. We ballooned it distally. We can leave it.
Yeah.
There's no dissection.
So that's okay. So now there is a trial we did called DART, D-A-R-T. And that trial was the trial of vessels less than 2.5 millimeter. And this is the data at that time. We didn't have much, stents, the small sizes. And so late 90s.
Yeah. Looks
Beautiful.
good.
Yeah. So that trial showed actually in the small vessel. And the plan there was rotablation versus rota plus PTCA versus PTCA. They found two things. One, less dissection after rota in those small vessels. And mean vessel size was 2.25. And the second was, go to epicranial, and second was the chance of stent use. So while in the PTCA group, stent was done almost in like 40-45% of cases, in the rota group was done only in 8%, single digit. So anytime when you want to avoid the stenting, doing a rotational atherectomy is the right approach, and we have the data to support that by the DART trial. I think based on that now, we should take care of the area. You can leave some area without stenting because we did not do balloon dilatation. The area which we did not do a balloon, just did a rota, is perfectly fine to be left alone and just stent the area where we did the rotational atherectomy followed by balloon. Okay, what do you think now? Well, lengthwise, because that's an important issue which we need to decide.
I think 28.
Okay.
28. We are going to stent across the diag.
Yeah, good.
Right? Then
Take a
don't do
center.
that. Let's do balloon. Right?
Huh?
Because his creatinine is high.
Yeah.
What do you want? What size?
No, IVUS later. No, IVUS will do in the end. You want to get a 2.3020 balloon?
3.5, no?
Yeah, balloon.
3.5
Yeah.
vessel.
Okay. 3.520 high pressure balloon. Yes, question.
We can put a 3.0 and then post dilate the proximal.
Yeah. So question will be that do we cover the diagonal or not? You have to cover the diagonal. Look at the lesion after before the diagonal, the big vessel narrows down. And then the big question, and that is the still a lot of papers keep coming, that do you jail the side branch? And does the side branch jail? The recent meta-analysis in Jack intervention showed that leaving the side branch didn't make difference, but it did. The retrieval of if your vessel went down, leaving the side branch wire did help to restore the flow, but overall occlusion was not different. closure of the side branch was not different. So this is a 3.5 20 at 16 atmosphere.
Didn't open.
Didn't open. This is 20. Just one second. Leave it
opened.
few seconds. Yeah.
Open now.
Fluoro. Yeah, good. It opened up nicely at 20 atmosphere. So many ruptured. So balloon rupture is actually ruptured at 20. But now then you have to be worried about at that time some air embolism and so. But now that means we can just go with the stent directly now.
So what you want?
3.25. 28.
3.25, 28.
Yeah. 3.25, 28. Yeah.
Why not a DEB, that is a regulating balloon, instead of a stent distal? When do you prefer
such a long segment? Yeah. But remember, once you have such a long segment, the small vessel, DES versus BMS, drug-coated balloon, take a picture now. The choice here, at least in America, is very simple because we don't have a drug-coated balloons here. That's one. Second, such a long segment, I would say that yes, you can make it a PTCA and then the IVUS guidance and do stent in the area where the drug-coated balloon have not nicely opened.
High pressure.
So that will be the only indication. But yes, a small,
15.
moderate lesion, because such a long lesion with a drug-coated balloon also in a native vessel will have a very high restenosis. So here in United States, we are limited. While our Indian counterpart have the access to the drug-coated balloon, we don't have it yet. We are just starting the trial in next few weeks. Few centers have already started some coronary trial. FDA gave a very tough time because of the earlier data of higher mortality in the peripheral drug-coated balloon arena. Although coronary, lot of paper have come out that no longer higher mortality in the coronary group, but they still follow that same, and they're barely starting the trials now of the drug-coated balloon. Yeah.
Yeah.
But yes, short segment, I would say that such a long segment, even if it is available,
Yeah, go.
okay, I would not go with a drug-coated balloon only. So what I can do, if there is a concern that you want to just do a drug-coated balloon, so then I think it will be a reasonable, this is 16 atmosphere. So reasonable that you do a nice balloon dilatation and then your drug-coated balloon, then do imaging. And if you don't get a lumen of less than or more than 3 millimeters square in that moderate size vessel, in that case, that area you do a focal or spot stenting. But this, such a long, we know that with a drug-coated balloon is not the answer for that.
Okay.
Yep.
Another question, how to unwind the rota wire loop in the aorta?
Yeah, so very simple that what you need to do is, you need to bring it back, the guide out, and try to straighten out your, as we did in our case, try to straighten out the burr. So once you have straightened out the burr, then you are able to advance your reposition. But that's the only way. So many times there is a very big loop when you try to pull it, but that time is very important. Your guide should be out, and the guide should be out, and of course the burr will follow that path. Yeah, looking very good. See that now? That area, we dilate with a 3.5.
No, 8. Give me an 8 millimeter balloon.
Okay, so that area now is still there, not fully open. We saw that in the balloon also. We had a.
No, I think we didn't go there.
Huh?
We didn't dilate there.
So that was opened earlier, and now.
A little bit distal,
Yeah.
which we didn't go.
But it's within the stent.
Mm-hmm.
Yeah. So this area
We
was
will
not
go
fully.
with get a IVL ready.
So that always question comes to your unexpanded stent.
IVL ready.
Then what else can you do acutely? Acutely, we know that you can use laser, you can use IVL, although IVL is not indicated for that purpose, because it is what the effect of IVL will be in the drug at present is another big issue which we do not know yet. But then yeah.
When do you pre-dilate the rota after rota?
Yes.
Before stent?
Pre what?
Yeah.
Is there any strategy, and when do you pre-dilate?
Always, we always pre-dilate. After rota, before stenting, always we pre-dilate.
100% pre.
100%. I know a lot of people believe
Like
that
here now we had a ruptured balloon. Nothing wrong in thinking that you want to go with a cutting balloon and go back. But if you
Okay.
are in a conference, everybody will say, okay, go do imaging. But I'm telling you, without conference and without imaging, this is the case where we know
little bit
that
in.
it's telling us that there is some calcium nodule, calcium spicule, something
Good.
that's not
Going up.
been taken care. So then we should have probably handled with a cutting balloon. Yeah.
Do
Now
you
we
think that
opened
the
it.
Rota plus IVL is a better option?
Yeah. So I think if the cost is not for the IVL, the Rota routinely when you want to post dilate, use IVL. Particularly in a large vessel where like this case 3.5, use a 1.75 bulb.
Okay.
You're less than 0.6, sorry, 0.4. So this is a 3.58
Okay, down.
at 18 atmosphere.
So,
So-
you understood now, since there was a short unexpanded area or where it was stented, we just went with a 8 mm balloon. So you go focal, 8 mm, high pressure, 22, 24 atmospheres. We went to 20, 22. That's how
Okay.
that area opens up. Now, if this had not opened up, I already called for IVL.
We don't need IVL,
But
yeah.
we don't need
Okay,
IVL
Chennai.
now.
And we'll confirm all this with our
IVL.
IVUS. Look at this.
So
Beautiful.
now it looks good.
Oh,
Now hold on.
good.
We're
Yeah.
going to post. Hold on. Proximal.
Huh?
For now, proximal we have to do here.
Yeah.
Okay.
Okay. Going up.
Strategy of not doing an IVUS before rotablation here?
Mm.
Or
No, this case we did not know. We knew about such a calcific lesion. To me, in a very calcific long lesion, your imaging pre may even create a problem. What can create problem? With the OCT, there will be no flow. Patient will develop slow flow or maybe even VFib. With the IVUS, if you try to push it, with a very soft monorail may lift up the plaque and make it acute. So doing the IVUS after some atherectomy is fine because we are not going to see anything different than what we see there now. You saw it, such a tremendous calcium angiographically. So that our paper in JAC about 5 years ago, 6 years ago actually, we emphasized that point. If it's a severe calcium, which is a tram track, you may decide to do IVUS, but or OCT means imaging, but that probably should be the final to see your results, not to make the diagnosis.
Go all the way down.
Yeah,
Huh?
not to make the diagnosis that you need to do whether you need to do Rota or not Rota. So in a moderate calcium, probably doing the imaging is really important. That should you use the atherectomy, IVL or so or not. So that's the point.
This is, I'm not going down. Okay. Leave it there.
Yeah,
I
good.
want to go down.
Okay. I
It's
was
only the mid LED stent. Okay. You need a little flush.
put IVUS on the same big, yeah.
Yeah,
You
it's
can
a
see
gap
it.
part, not one flag, remains open, it's coming. It's a gap part.
You're not even in the
It's a
stand.
distal edge of the stent. Yeah, looks perfect, very
Yeah,
expanded.
yeah. Now we understand.
Normal apposition, very expanded. Looks good. It's coming. It's yeah, it's a little bit elliptical shape. I can check the area later. A little bit black. Can you flash a little bit?
Yep, we're doing it again.
It's better. Yeah, the proximal part is very expanded. Still in just stand. Just stand looks good. Now I see the branch, and this is the proximal part. Yeah, lumen is open.
Fluoro. Yeah.
Yeah, now it's a proximal NATO.
You pass the diagonal. See the
Yeah,
big
yeah,
diagonal.
That was good.
And the proximal stent is done. Yeah.
So I can.
So let's analyze it now a little more.
Okay, I stop and I check the tightest area.
But look at the angiographically. All the branches remain great. See that? The diagonal still remain the same way. All the septals are there. And that is the advantage of rotational atherectomy. That is, prevent the side branch closure. Which otherwise with such a diffuse disease, multiple stents, very high chance.
So actually,
So let's discuss the IVUS, whether we need to do anything further.
I mean, post is 5.3. So I think we can leave it.
Yeah, like almost 5.5. It's,
Yeah,
I
yeah.
think it's accessible in such a calcite region. I can see the behind the stent a lot of calcite plaque. That's why it's so shaped.
Angiographically, it's
But the
bulging.
area is 5.5. I think it's acceptable.
Yeah.
Yeah, I mean anything more than 5.5 is okay. And in the distal vessel, we get about 3+ or no?
No, we didn't go there.
And there's no malapposition, no edge dissection.
Okay.
We didn't go to the distal LED.
Let's take the caudal picture. So we always try to do last picture in the low mag. Beautiful. Delay, try to see any wire. You know, many times those things happen. The wire perforations and so no movement of the camera, and you have seen it completely. And look at the whole vessel has plumped up so nicely.
Yes. Very impressive result.
Yeah. So, and we confirm with the IVUS.
What happened to the Impella flow guy?
Yeah, what happened to the... Huh? So there is a somehow attenuated flow. You always have to worry about. Yeah. What was it? Yeah. Okay. So key is the advantage of Impella, we are able to do our procedure at ease. So one of the things Impella does is that you are able to do your procedure at ease, not rushing into it. So even time to time, we saw it when we did, blood pressure did go down to about 70, 80, but we know that the,
Okay.
yeah. So 70, 80 and so clearly that at the need for Impella was appropriate in this particular case. But yes, if there was an issue with the finances, like many times happens in India, I would do this case with a balloon pump at least. So no question. I'm doing the case in ESCC, my hospital in Jaipur. I'll do minimum balloon pump, preferably Impella, but Impella knowing that it's a 16 lakh rupees cost. Very few people agree, but we still do. So of my 6-8 cases, almost everybody gets atherectomy because of complexity, which I'm there on this Friday and Saturday. But the key is that use the balloon pump at least. Use a balloon pump for these patients. So any points, any further discussion from point of view? Let's connect the groin directly. So that we see the tracings are a little attenuated, maybe with the sheath in.
I don't know. Let's see. Wait.
So always have to worry about that there is no thrombus in the system. That happen particularly, not acutely happens, but when you go take these patients, leave the Impella, even if you give the heparinized solution and give heparin, that we have seen cases that losing complete tracing because there is a thrombus in the system, because very prone. So you have to keep it PTT of 90 and so in these cases. So now this is here, and then you go gradual from the P7, gradual step going down, we are already to P3. And what is the maximum outflow, maximum output in this particular case today? 3.5. So remember they say 4, but rarely get to the 4. But 3.5 was the maximum output. That's okay also. I say that don't worry about it. And CP probably the best one in the cardiogenic shock. Although that's where the data. Although the trial wants every case with the CP and the Protect 4. But really the cost difference, like in India, 3-4 lakh rupees, I would completely fine to do it with the 2.5 LP, which gives the cardiac output of about 2 liters. And that is what you need in high-risk cases. You don't need, because you have additional, in the cardiogenic shock is different. In high-risk PCI, in my opinion, it's a 2.5 is good enough because there is a big difference in the cost. And same thing here. The cost of the LP, which is 2.5, is $18,000, and CP in America is $25,000. 7,000 difference, just like a 4 lakh rupees difference in India. So it's corresponding the same way. But key is now the whole science or push by the company and everyone has been on the CP. So this is CP is the one available, and so all future cases all will be done with a CP.
There is a question coming up. Why not IABP use?
Yeah, could be IABP. That's fine. I mean, again, remember the IABP point is, no matter what we say, IABP, we have all the trials, BCIS in the high-risk patients, trial was beneficial only after 5 and 10 years and so, but it decrease the complications. It definitely decrease the complications of the patient acutely, but in this case could be IABP fine. The only question is we don't have any trial to say IABP is better than Impella. But we have the enough data to show Impella is better than IABP if you take it to a Protect 2 trial. And same way. So although the non-registry data recent came out again showing that use of MCS from the Medicare, the database that was associated with higher mortality, a patient with a cardiogenic shock, and the higher cost, and so on and so forth. So always remain. There is a question, but truly, the whether should use a balloon pump versus Impella. In this particular case, let's say you have a choice. You're a little financially constrained, and you want to do the right thing. So if your EDP is high, I think it's a good case for Impella. So EF of 28%, less than 30%, high EDP, Impella. Your EDP is 10, ejection fraction same, less than 30%, 28%, you want to do complex PCI, balloon pump is good enough.
Okay.
So we have a total contrast use of 140 cc with the air karma of 1.5. Yeah.
Okay.
Total time of 27 minutes. Yes.
Okay, so if there's no more questions, so we can conclude our this live case here, and we start the presentation of the chip complex case, and I'll join you in few minutes.
Yeah.
Okay, thank you from Mount Sinai Cath Lab.
We congratulate, and it's a very interesting case, and probably you have shown a very complex PCI in a simplified way. We really congratulate you and your team. And before you join, probably I think we'll start with our presentation by Dr. Karunakar as a mechanical support assisted PCI.
Beautiful.